I'm going to talk a little bit, or a lot, about operating on the inoperable. As cases get more and more complicated and patients become more and more high risk, we are being asked to do tougher things on more difficult patients. So that's what we're going to talk about today. I am the Chief of Pediatric Cardiac Anesthesiology at the Texas Center for Pediatric and Congenital Heart Disease, which is a collaboration between the University of Texas at Austin Dell Medical School and Dell Children's Hospital. And here's a picture of the medical school at mouse at the top with this shell on it. Does that show up? No, it doesn't. Okay. And Dell Children's Hospital. I have no disclosures. And I have this perspective on the inoperable because I am a very, very, very busy, hyperactive cardiac anesthesiologist. I've been at Dell Children's for over 4 years, and I've done about 800 cardiac operating room cases during that time. That's about 4 cases a week. What we're doing takes intensity, and we're operating on people with the highest complexity, and we have a tolerance for risk within the program. To say this again, I think you saw it earlier this morning, the outcomes in congenital heart surgery are optimized by surrounding the patient with the greatest expertise possible during all times of the surgical and post-operative period. We believe that, and we're relentless about that. Dr. Fraser shared earlier about some of our most recent outcomes. The most recent STS report that showed that our outcomes were, for the first time, significantly lower than the national benchmark. And that designation is usually achieved by only 8 to 10% of congenital cardiac programs in the country. So we have this lower than expected mortality, but we have a patient population that's becoming more and more complex and being referred to us as inoperable. So the outcomes reporting, they're good for some reasons. They're good for benchmarking, for facilitating competition, for people to see where they are and for them to try to get better. And it also increases the information that the public has, and for patients who are looking for care and for the medical community who's referring for care. But there are some inadvertent consequences, and that includes risk aversion. Because if a case is going to make your numbers worse, should we be doing that, or should we be referring that to somebody else? So we've developed a reputation for taking on high-risk cases. Transplant candidates at other centers have turned down complex fetal and neonatal diagnoses that are high risk, like hypoplastic left heart syndrome with total anomalous pulmonary venous return, ectopia cordis, and right now we have 2 of those in our ICU, and you saw some of the pictures of those this morning. And then also complex pathology in patients with high-risk patient factors, like a transposition and an 800-gram neonate, and aortic and mitral valve stenoses in a patient with Hurler-Scheie syndrome. And then a third case, a partial anomalous pulmonary venous return in a 72-year-old patient. So our philosophy on risk is as follows. Collectively, we believe that every patient does deserve a chance. And if we think that we can help a patient, we will put together all of our tools, all of our expertise, and we're going to do that. The components of the philosophy include a strong methodology and approach, anticipatory management, communication, which we all know is paramount, psychological safety, and focus and intensity. For the methodology and approach, there are principles that we adhere to. They're learned, they're taught, they're refined, and there's an understanding that we are not being risk averse. Some of that methodology and approach involves the standardization of equipment, of procedures, of the anesthesiology portion, the perfusion, nursing, the operation, the intensive care model. The team approach, we know that nobody in the room can do their job alone. And so the operating room is set up to facilitate communication and allow each member of the team to perform at their very best. In terms of anticipatory management, that includes things like multidisciplinary planning, having a strategy of being proactive, not reactive, preparing for the worst all the time, and the standardization and the setup for the whole team so that there aren't days when things look different in the operating room than other days. As far as communication goes, we've talked about that before today. Communication should be clear, loud, scripted, and there should be a readback for confirmation. The environment should be maintained in a quiet, organized, controlled fashion with line of sight between members of the team. And then again, which we'll talk about in a moment, psychological safety and the comfort to raise concerns. Now, psychological safety is kind of been a little bit more important to me. And when we talk about some cases later on, we'll talk about how that has allowed me as an anesthesiologist kind of a safe space to push the edge of the envelope. Because if I just did things the way I always did, then there wouldn't be any innovation in that. And as far as the focus and intensity, we all acknowledge every day that this is serious work. It's not playtime. We're aligned in the mission, and that's demonstrated in our OR conduct and environment. So I'll talk a little bit about this 800-gram arterial switch operation. You've seen some pictures. You've listened to Richard's really good explanation of exactly what he did. And we'll talk about it from kind of a global standpoint. So this is an operation that we know very well. And we do this operation a lot. And we do it the same way every time. The anesthetic is virtually the same. The perfusion is conducted in the same way in the operation. So I can predict exactly what's going to happen. The difference in this case was that the patient was smaller and she had significant risk factors due to her size and prematurity. And the survival in this case depended on a successful operation and successful management of her comorbidities. So here's the same picture. This is the game plan that was worked out with all the members of the team and really thinking about exactly how we were going to do that, from the transport to the line placement to the operation itself, the perfusion, the ICU care postoperatively. As far as the methodology and the approach, I did the same thing that I do for a regular switch. We changed the endotracheal tube to make sure that we could breathe effectively for the patient. I placed an arterial line. I placed a central venous line. We positioned the baby with care. I had the same drips available, albeit in different size syringes, to allow for the small volumes that would be given. But the methodology and the principles were the same. The focus and intensity was the same. It was very quiet in that room, and I believe I held my breath a lot. But the way we managed the operation was the same. Again, that patient survived the operation. She survived her perioperative period, and she went home to join her sibling. Another case, which you also saw some pictures of, was a case of ectopia cordis, a baby who was born at 37 weeks with ectopia cordis, tetralogy type DRV, and he was not offered treatment outside facilities that do perform congenital cardiac surgery. And so they sought care with us, and we accepted them. Now, I haven't taken care of patients with ectopia cordis before, but I take care of a lot of neonates. And I use the same principles, the same methodology, and the same approach that I would to a neonate who didn't have their heart beating right in front of me outside the chest. The baby was transferred on the day of life 4, and he had surgery on day of life 8. I did the same things I usually do. I transported the patient down the hall with the family to the hug zone. We took the patient to the operating room. We induced anesthesia. We intubated while trying not to be distracted by the heart beating right in front of the laryngoscope. We placed arterial and venous lines. and we prepared to go on bypass. So the patient was prepped for surgery. The heart was mobilized and able to be brought down into the chest and then covered by flaps and by allergen. Now, going into the operating room, we didn't know what we were going to do. We knew that we were going to try to cover the heart. We didn't know if we were going to go on bypass. We didn't know if the heart was going to be mobilized and moved down there. So we were ready for all of those contingencies. The baby was ventilated and the endotracheal tube was proper for a bypass case. He was fully lined up for a bypass case. The pump was primed, although we didn't use it. And we had every medicine that we would normally have. We weren't distracted by the fact that his heart was beating on the outside of his chest. This is another case that I think illustrates the psychological safety that's developed within this program as far as the anesthetic care. This is a teenager who presented with dilated cardiomyopathy for a HeartMate 3 placement. And as an anesthesiologist, the kind of things that I was taught were, one, a VAD's going to need a lot of blood products because they're going to bleed. And two, you need to manage the right heart post-bypass. That means leaving the patient intubated, ventilating well, hyperoxygenating. You may need nitric, and you may need some right heart medicines, things like some epinephrine or some Milrinone. So I kind of challenged that thinking, and I said, you know, this is a fresh chest. He has not received any blood products in his life. Let's not prime the pump with anything blood product related. As he was going to be listed for transplant, that would lead to a decreased risk for sensitization and potentially a longer graft survival. So we talked about that and whether, you know, that would be, you know, a good idea, and we decided to go with it. You know, we were starting with a healthy hematocrit, and we had an estimated crit on bypass that would be in the high 20s, low 30s, and we decided to roll. And we managed to do the case with no blood, no FFP, no platelets, no cryo, no anything. And so we felt pretty good about that. And he didn't get any blood products in the postoperative period either. The other thing, which I'd never done or even really thought about, was the potential for an NOR extubation of the patient with the VAC. So in thinking about it, you know, this was a teenage patient. He had a good airway. If we planned his anesthetic so that he could be extubated at the end of the case, we could have better right heart function through spontaneous ventilation. We could still deliver some nitric oxide through a nasal cannula or a face mask at the end. And so we talked about that as a group and whether that was a good idea, and we decided to proceed with it. That led to an NOR extubation in a patient who was playing with his phone 2 hours after the operation. It was like he had a knee scope. He had early mobilization and he had a decreased length of stay. Now, I would have not done that had I not felt comfortable to say, you know, can we think of this differently? So I think that that's a real benefit of working in a group like this. This is another patient, an adult plus congenital patient. He's a 72-year-old with partial anomalous pulmonary venous return and COPD. He lived out of state and nobody would operate on him, and he sought care and he sought an operation to fix his PAPVR, but multiple centers turned him down. He came and found us, Dr. Fraser, in Austin, and we said, I think we can do this. And so he flew in and he had an operation, again, an operation that we know very well. And again, we conduct the anesthetic, the perfusion, the operation in a very standardized way. And this says he has significant risk factors due to size and prematurity, but he has significant risk factors due to, advanced age, not that advanced, and COPD. And so his survival depends on a successful operation and a successful management of his comorbidities. So again, the methodology and approach was the same. we treated the patient delicately. He was an adult, but we treated him like he was an 800-gram baby. We were very gentle with him. We were very gentle with the perfusion, with the anesthetic itself. And then we anticipated the issues due to his comorbidities, like difficulty breathing, like problems with delirium postoperatively. And again, we talked about it in the operating room. Do you think I could extubate him? No, I've never extubated anybody that old. But I think that was the best place to do that. We took the time to do it. We extubated him awake, and it avoided at least 1 to 2 days of postoperative intubation with other medicines that would maybe scramble his brain, make him delirious, and allow him, prevent him from moving along. So we did that. He was thrilled. He became the most popular patient on the unit, and he was discharged home and came back. He calls in to tell us how he's doing, and he's doing well. So for my conclusion, at Dell, we're continually honing our skills and our approach. And it's serious work being done on the behalf of the patient. And I think with our program, we've been allowed to push the edge of the envelope and kind of do things that we would not have done before. So I am grateful to be here at Texas Heart speaking to you. I'm grateful to be in Austin doing great work with great colleagues. And thank you for having me here today.